Hi guys, welcome back to BROMED Lectures. In this video, we're going to cover hyperthyroidism. Now, let's begin with the etiologies of hyperthyroidism. Of course, the number one cause is going to be Graves' disease. This is worldwide and in the United States. This is the one that we're going to focus more in this video. But there's also other causes. I'll make a parenthesis as we go through the video. But we're going to focus more on Graves because it is the most common one and is the most commonly tested one, okay? Toxic adenoma, usually adenomas do not provide hormones, but if they do, they can generate hyperthyroidism. Toxic multinuclear goiter, this is the second most common cause, and this is referred as plumber's disease. And this one in particular is due to autonomous nodules that produce the hormone and that are acting by their own regulation. Now, subacute thyroiditis, you differentiate them because of this symptom. If it is painful when you are performing physical examination of the thyroid of a patient and he has some of the hyperthyroid symptoms, then you have subacute thyroiditis. It may be because of a recent infection, maybe viral, some bacterial infections, mostly upper respiratory infections. And then the lymphocytic thyroiditis, this is painless. You may recognize it because it is painless and it is associated with postpartum patients. Now, there's other causes such as stroma ovary in the setting of a teratoma. Search for the adolescent patient, and factitious, the patient that gets the thyroid hormone exogenously. These are usually health-related job-specific patients. Now, with the drugs, the most common ones are the ones I listed here. The ones that you may be tested is amiodarone, of course, commonly appears on question banks and in exams, lithium, and contrast agents. Alpha interferon and spectrants are not commonly tested, but keep them in mind if they appear. The amiodarone patient is usually the patient that has a heart condition. Lithium, the bipolar disorder patients. Contrast agents, usually patient that goes for another diagnostic imaging study. They get contrast and they develop either hyperthyroidism or a thyroid storm, which we will further discuss in another part of this video. Now, the pathogenesis, we're going to focus more on Graves' disease, as I told you. The important thing about it is that you have this thyroid-stimulating immunoglobulin, and this is going to produce hyperfunction of the gland. This is considered a type 2 hypersensitivity reaction. You may remember from the step 1. And these are the risk factors. Women, as most autoimmune conditions, less than 50 years. It has a genetic component, of course, and the other autoimmune conditions related to this specific Graves' disease syndrome is diabetes mellitus, rheumatoid arthritis, and vitiligo. And of course, you have these B8 and DR3 HLAs are specific for this condition. Now, the triggers are going to be stress, any kind of stress, either surgery, infection, whatever. Some certain infections are related, and of course, pregnancy, as I told you, with the thyroiditis, but it can appear spontaneously. And now for the signs and symptoms, we divided it into the specific ones for Graves and the common ones for hyperthyroid patients. And so if you have one of these specific for Graves and any other related specific symptoms for hyperthyroidism, then you may or may not perform diagnostic studies because exophthalmos, as we see, is usually specific for Graves' disease. And so if you have exophthalmos and any other of these symptoms, you have your diagnosis of Graves' disease, right? Exophthalmos is due to swelling of the orbital tissues. It is usually because of glycans depositing behind the eye. You can even develop fibrosis of the eyeball tissues. And that's why the patients, if they have exophthalmos, they require another treatment, evaluation. And as I told you, the diagnosis is straightforward. because of it is super specific for this condition. Vertebral myxedema, the same pathophysiology with glycosaminoglycans. This is in the shins. They develop this edema. And also this one is commonly tested. Transient hyperthyroidism in the fetus. If you have transient hyperthyroidism in the fetus, then this is because the TSIs are IgGs. They can cross the placenta. It is specific for Graves because it is one of the conditions that has the immunoglobulin with the hyperthyroidism, and also neutropenia is commonly seen in Graves' disease and anemia. And now for the other, all other causes of hyperthyroidism, you may develop these symptoms. Nervousness, atrial fibrillation, they like to test in this one. Patient that develops atrial fibrillation and has no other related or associated predisposing condition, you may look for the thyroid hormones. Tremors, inability to sleep, the brisk deep tendon reflexes, diarrhea, weight loss, proximal muscle weakness. Compare these to other myopathies. Dyspnea, the patients may develop high output congestive heart failure, commonly tested. Hypertension, palpitations, warm and moist skin, heat intolerance, and if the patient has the disease for long enough, they may develop osteopenia and osteoporosis because of the stimulation of the bone turnover that these patients have. Now let's go through the diagnosis and treatment. And so if you remember from the axis that we talked about, the thyroid hormones are going to inhibit directly at the anterior pituitary, and they're going to lower the production of the TSH. So in these hyperthyroid states, you have an increased hormone with an undetectable TSH. Now, this test, the radioactive iodine, is going to tell you some specifics. If it is increased and you have diffuse increased uptake of the radioactive iodine, then this is Graves' disease. But if you have nodules of hyperactivity, then this may lead you to multinodular goiter or Plummer's disease, right? If the radioactive iodine is low, then this may lead you to think that this is a thyroiditis or a factitious disorder. Now, the specific immunoglobulin that you're going to test for Graves' disease is the TSI. If you have this, you have Graves' disease. You may or may not have antithyroglobulin and antimicrosomal or peroxidase antibodies. These are more specific for other conditions such as Hashimoto with the antimicrosomal, but they may appear positive in patients with Graves' disease or thyroiditis because of the inflammation and the formation of immunoglobulins against these components. Now, the treatment, you may want to follow this order. If they are asking for just to stop the adrenergic hyperfunction in patients presenting with acute conditions, then what you do is you beta blockade the patient, atenolol, metoprolol, whatever beta blocker may do the trick. The antithyroids, they have some specifics that may be asked. PTU develops liver damage. And so this one is used on the first trimester because it is non-teratogenic, but they usually change to methimazole at the second and third trimester. And this is because they are fearing the liver damage that PTU may lead the patients into. They both cause agranulocytosis. This is also commonly tested. So keep this in mind for the antithyroids. And now the last thing that you may do is either perform surgery or a radioactive iodine ablation, demolition completely of the thyroid gland. The question relies on this thing. If the patient has severe ophthalmopathy, then you want to perform surgery. This is your go-to, or keep with the medical therapy. Because if you ablate the gland, then you are providing more TSI to be produced, and this may lead you to worsen the exophthalmos, okay? So you want to avoid that. And this is the patients in which you either continue with the medical treatment or perform surgery. And now this last part of the video is going to be the discussion of thyroid storm. It is considered an endocrine emergency, and it's usually described as an over-exaggeration of the hyperthyroid patient, okay? The risk factors is usually someone that is hyperthyroid, but is usually either non-recognized or it is inadequately treated. So these patients usually have a trigger, and this is important because this is the way they ask in exams. It's usually a patient that has non-recognized or inadequately treated hyperthyroid state, and they have either thyroid or non-thyroid surgery, or they develop into an infection, some kind of trauma, and as I told you, iodine contrast induction. And now these patients rapidly develop this syndrome, which is tachyarrhythmia, hyperpyrexia, tachypnea, vomiting, diarrhea, restlessness, dehydration due to the vomiting and diarrhea, increased muscle activity, and they may develop into coma. So these patients need to be acutely treated because what you want to do is to lower the symptoms, to lower the patient developing a coma, right, or dehydration. So what you do is you need to beta blockade the patient immediately, and you can do this, or either you can have PTU. The reason behind PTU is because it inhibits the peripheral iodinase, and so deiodinase, I'm sorry, and so this is the only one making this effect. The methimazole won't do the trick. You need to have either PTU or metoprolol or atenolol. Now, next thing you need to do is to inhibit the hormone release with iodine. You load the gland with iodine, and it is gonna lower the release of hormone, right? And some books describe the use of dexamethasone, and this is because the adrenals are not going to be able to keep up with these rates of thyroid hormone release, and so you need to give them a help with the dexamethasone, okay? So that's going to be for the video. Hope you consider all of these thyroid storm and hyperthyroid states, and I'll see you in hypothyroidism.